For now, though, we should move on to our second topic for discussion today, and that's the impact of CML on fertility and pregnancy. And we have another two great speakers. Can I please introduce Dr. Carla Boquimpani from Rio de Janeiro. Carla is a very well-known physician in the region. She's the head of the Hematology service in ONCOCLINICAS group. She is a technical director in the Health Foundation of Rio de Janeiro, and she is a principal investigator in many clinical trials in the State Institute of Hematology, Memorial, and CML. So welcome, Carla. And our fourth and final expert today has done a great job of introducing himself and spreading his expertise already. And that's Mike Mauro, Professor Mike Mauro. So Mike is the leader of the Myelopropliferative Neoplasms program. He is a member of the Memorial Sloan Kettering Cancer Center, and he is professor at Weill Cornell Medicine. Welcome, Mike. Such a privilege to have both of you here. So Carla, if you would please share your slides with us. And the intention is again to have two cases. So Carla will spend a few minutes identifying key issues and problems, etc., in the area. She'll then present a case. Mike will comment, some questions from the audience, a second case. Mike will comment, some questions from the audience, but again, it's a short period of time. Let's see how we go. Let's be flexible. It's very important that that these meetings are inclusive and you have the opportunities as an audience. So we'll start and see how we go. Thank you, Carla.
Hi, everyone. It's a pleasure to be here with you. Thank you so much for this invitation. I'd like to congratulate to Arlene and Nicole. It's a great pleasure to be with you. Then, if Professor Mauro, we will discuss about fertility and pregnancy in patients with CML. Then I would like to explain about there are four different scenarios in CML in pregnancy. The first of all, and I think that's more common, is when the patient is diagnosed with CML and suddenly unexpected pregnancy happens. Then in this scenario, many things could do. The treatment is different if the treatment of CML is in the beginning of the CML, or when the patient is in complete molecular response. The other scenario is when the patient is pregnant and suddenly the diagnosis with CML is done. Then this is very difficult because the patients need to begin the drug, but she's pregnant. Then this is very difficult. Other scenario is when the patient is the man, then her partner is pregnant. This is easier. And the other scenario is when our patient is with CML, she wish to become pregnant. Then TFR is very important for this. In this case, I'd like to share about the scenario in Brazilian health public system. We have this. You can see that each year, the orange line, we can see that each year more than 1,500 patients are diagnosed in Brazil each year. Then we don't have more data after 2018 because of pandemic, but we can see that the number is increasing each year. Then this is a great challenge, because if you can see this line is increasing a lot. The mortality in Brazil is about 400 patients each year. Mortality for CML or for other comorbidities or other case in CML patients. And each year we can see that 400 patients they died, and each year 2,000 patients are diagnosed. Then this is a great challenge, because we can think that in 2030, we will be we'll have more than 40,000 patients with CML. In 2050, more than 71 1,000 patients with CML, then this is a great challenge for us. If you can separe the patients by sex and by age, we can see that 55% are male and 45% female. And I would like to emphasize that this group of patients, they are in the number of patients, we have more than 4,000 patients with CML and more than 2,000 women in childbearing age. Then all of these women, they are in the age that could be pregnant. Then we need to teach them. We need to educate these patients that they need to prevent about the pregnancy. I'd like to share firstly about some Brazilian cases. This is old, this data. Then I'd like to thank my colleagues, Brazilian colleagues, Katia and many others. But I would like to emphasize that these pregnancies, 69, in this group of pregnant patients, we had 51. They were healthy, 3 abortions, 1 premature, 2 stillbirth, 1 autism, and 1 Down syndrome. Then this is not a study. This is only a group of patients that my colleagues send me about their cases in pregnancy and CML. I would like to share about the clinical case, the first one. This case is a female, 22 years old. She was diagnosed with CML in 2019, chronic phase, and her transcript B2A2, so-called low risk, and the cytogenetic is normal, like the 922. Then that patient, she was treated in private system. Then we were able to begin nilotinib. This is not possible in public system Brazil. In public system, we only can begin with imatinib. Nilotinib was to 12 months. We cannot do the PCR in 9 months because of pandemic. Then in 12 months, 1 year using nilotinib, she achieved the major molecular response. She continues in major molecular response. In February, the same result, 18 months after, and 21 months after, she continues in major molecular response. Then she had a very good adherence to nilotinib, and she achieved the only major molecular response at that time. But in July 2021, the patient became pregnant. Although we explained about the pregnancy, but she became pregnant, and she was in 4 weeks. She was in major molecular response at that time. The nilotinib was interrupted. In October 2021, the patient lost hematological response very fast. She was in major molecular response, but 3 months after, she lost the hematological response. Then the PCR was 7%, the increase in the PCR. In November, 1 month after, the leukocytes increasing, but it's not so fast. In Brazil, we have some problems with interferon. That we couldn't use interferon for her. Then she continues only with accompanying the hematological response, but the leukocytes not increasing more than 15,000 leukocytes. In January 2022, she had a normal cesarean. The babies with no abnormalities, breastfeed only during colostrum. Then in February 2022, 2022, she started nilotinib. In May, she achieved the major molecular response again, very fast again. In October 2022, she maintains the major molecular response, and the last January, she achieved the complete molecular 4.0. Then the patient and the baby, they are okay, very good. The family is very happy. Then this is the finish of the first case.
Sorry, I was on mute. I said I like the ending, that everything went so well. You know, I think that represented good early treatment, and the timing of the pregnancy was, you know, given your 4 scenarios, more of the manageable type where the patient has disease control. You know, when I think of the journey that patient had, it would have been nice if a little bit more you know, if the pregnancy could have been deferred until there was a deeper remission, or maybe even there could have been opportunity for a treatment-free remission. I personally am very keen to support women and their fertility and opportunities for pregnancy. And I try to merge the agendas of TFR and pregnancy when we can. It's not always possible though. And then this really represents what happens when we stop therapy, and maybe not under ideal circumstances. I think it's interesting to point out that the kinetics of relapse might have been calmer than one might have expected. I have some observations, we haven't published them fully yet, but that the kinetics of BCR-ABL and leukemic relapse during and around pregnancy may be, in some cases, different, reasons unclear. It may have to do with the immune status of the state of pregnancy. This also represents the success of retreatment, same drug, same dose, and success. So again, I'm delighted that that was successful. So well done. And I'll just stop there.
Can I ask you a question, Mike? Sorry, is that okay, Aline? So you did say the kinetics of BCR-ABL is different. Is that a general statement in pregnant women in general? I thought, I was a little bit surprised that this patient had 7-point-some%, and then she didn't restart nilotinib until February. I don't know what percentage she had by then, but I thought maybe this is an unusual case, or is this an unusual responses in pregnant women in terms of the different immune function?
I don't think we have a lot of information. We certainly don't have a lot of published information. I think we have registries, and we have an emerging data set and guidance around pregnancy and CML. I have some observations and some collaborative observations in different centers across Asia and EU and the US, where we believe we often see kinetics of leukemia relapse that might look different during pregnancy. I don't know if that's confirmed, or I don't have a mechanism, but I agree with you. It is intriguing that the white blood count wasn't very different, and the patient didn't get into a leukemic emergency or a need for retreatment. So that's good news. But I think we have to be prepared for that, though, because that still can happen. There is literature to state that women who interrupt treatment or aren't fully treated, aren't treated as long as they might be, especially limited treatment, who then stop therapy for pregnancy, can have a stormy course and can have progression of disease. So we have to assume the worst, unfortunately, but recognize that better outcomes are possible, and this is a good outcome. I think Carla wanted to ask me about interferon, maybe, and I think that there's some healthy skepticism as to, is it possible to really use interferon effectively in the limited time we have during pregnancy to titrate the dose and to get control of CML? I think that's probably a great point. My experience has been that it's useful. I've seen it control CML that's proliferative to allow women to get to delivery safely without risk of complications during delivery, thrombotic or hemorrhagic, or for leukostasis, etc. So I think it's possible. I also would say it's the most studied and safest agent to use during pregnancy, especially beyond the first trimester. I think many people think it's safe actually throughout all of pregnancy, whereas TKIs are at best controversial. And hydroxyurea is frowned upon at any point during pregnancy, as are other, alkylators. So those are some comments.
We don't have nilotinib in Brazil. We have, but it's this time we have some problems with PEG interferon, and in this case she couldn't have access to PEG interferon. I have a question for you, Professor Mauro. In the third trimester, I am afraid about to begin the nilotinib again during the pregnancy. I prefer continuous accompanying the leukocytes, and as the leukocytes not increasing, I preferred at that time to wait for the delivery, and after delivery to restart the nilotinib. If the leukocytes increasing faster, could you think that this could be a good idea to start nilotinib at the third trimester? What do you think?
I think your thoughts are very conservative and wise to balance the risk. Yeah, the drugs, in the U.S., the way the phrasing is that they're pregnancy category D, which maybe that's an international categorization where they're only to be used if the risk to the mother outweighs the risk to the baby. However, if you look at registry data where women have used TKIs during pregnancy, probably dasatinib is amongst the most difficult to be associated with birth defects and harm to the fetus, especially early pregnancy. Nilotinib is actually probably one of the least associated with effects on the fetus. And I think most obstetricians would say that very late in pregnancy, near delivery, there may not be much risk from TKIs. However, this is all speculative, and I think we have to just be careful about what we say and recommend. However, I think options for a woman who has a rising white count near delivery could be leukapheresis. I think interferon, there may be very little time to really gain benefit. And I know that there are many women who have been given TKIs very late in pregnancy in the third trimester with relative safety and good outcomes. So I think it's a consideration. I just want to be careful not to endorse that it's something we recommend or it's authorized. We have some data to suggest that there's differential toxicity depending on the drug, and nilotinib and Amanda may be safer than dasatinib, for example, and it's a case by case, and it's risk to the mom versus risk to the baby, and what kind of CML scenario is happening.
Good.
I see there's a comment in the chat about the if it was necessary, why not start imatinib in the third trimester, which I think is echoing your point, Carla. So I think we've covered that.
I saw a question. If it was necessary, why not start imatinib in the third trimester? Yes, we saw about this. Sorry. The second case, I would like to thank Katia Pagnano. She sent this second case. Then I will explain about the case of her female CML diagnosed in 1997, 14 years old, no comorbidities. She was a teenager, and the transcript B3A2, the cytogenetic is normal, not the translocation, Philadelphia positive. The treatment she used hydroxyurea and interferon alpha. Katia lives in São Paulo. São Paulo is a rich state. Then they have interferon. Sorry, it's a joke. Imatinib 400 milligrams was started in June 2002. Then the patient was diagnosed in 1997, and the imatinib was available in June 2002. Then until October 2005. Then the patients had resistance because of a mutation, this mutation. And she started dasatinib in clinical trial in October 2005 until November 2011, 6 years. Then she achieved MMR. But the dasatinib was interrupted because of the pregnancy as my first patient. she was 7 weeks in the pregnancy. 28. At that time she was 28 years old. The status of interruption, she was in MMR, and she lost response only 1 month after the interruption of dasatinib. She started interferon alpha in December 2011. The delivery was normal, premature, 35 weeks. And then in June 2008, this baby was low weight and no anomalies, no loss of hematological response. In the dasatinib, 100 milligram, was introduced in July 2012. The patient recovered the MMR in January 2013. The question that Katia did, would you give interferon alpha during pregnancy in this case, or only TKI interruption? What would be the risk for the fetus of dasatinib exposure at the beginning of pregnancy? This case will continue, okay? But if Professor Mauro would like to answer, to respond.
Sure. I'll work backwards and talk about the second point first, that we touched on this, that I think of the data we know, I think dasatinib may have a greater risk of harm to the fetus early in pregnancy, so I would not recommend that at all. The cases of birth defects that are not compatible with life or that are very serious have been unfortunately more often seen with dasatinib exposure, so I would not do that. However, we have to manage the case. So the woman is in an MMR and she becomes pregnant. I'm glad to see that it was only 7 weeks that into pregnancy before the TKI was stopped. I think probably the most harm can come during the most critical weeks of organogenesis around, which are probably about to occur at that point or are occurring. So maybe it was in the nick of time, as they say. Your first question, Carla, or maybe the collaborative questions from from where the case came was interferon. So I would definitely consider it, because again, I think only being an MMR, I think we have to prepare for the likelihood of loss of MMR, loss of cytogenetic and maybe even hematologic response. Where's the threshold to treat? I think I would say it depends on who you speak to. My personal threshold to treat would be when someone loses cytogenetic remission, when their PCR rises roughly to 1% or higher. You're between 1 and 10%. I think that there's perhaps a more rapid kinetic rise after that, potentially, although we did mention earlier that it may not be. I think you have time to potentially see if interferon can work and proceed if you have access to it. So I would be prepared to use interferon, talk to the woman, hopefully gain access to it, but not start it empirically unless there was a clear evidence of rising transcripts, but not allow it to get out of control, if you will, and start it conservatively, maybe when cytogenetic remission was lost.
Very good. And this case will continue because in October 2019, 7 years after, the patients had the dyspnea, moderate force, leg edema, and then the X-ray showed pleural effusion. The echocardiogram showed severe pulmonary hypertension. Then the dasatinib was discontinued at that time. In December 2019, she started nilotinib. She did catheterism in February 2020. No pulmonary hypertension. Then she continues the nilotinib. In December 2022, the last December, she was pregnant. At that time, she is 4 years old, and the nilotinib was interrupted. The question of Katia: would you give interferon during the second pregnancy, and what would be the consequence of nilotinib exposure? 2 pregnancies, and with dasatinib, the first one, and nilotinib, the second one. And today, the patient is in complete molecular response 4.0.
I see that Katya has her hand up, so I want to give her a chance to ask a question. You're muted, Katya, so now you're not.
Hello. Hi, Mauro. Hi, Carla. How are you doing? I was very concerned about this patient at the first pregnancy because she was resistant to her previous treatment because she was a patient that started very late imatinib because we didn't have access to imatinib at the time she had the CML diagnosis. And she had a resistance mutation, and she lost very quickly the response after the interruption. So I was very worried the first and also in the second pregnancy as well, because of this past of resistance. But as you see, if at least she's fine, and she had a very successful pregnancy in the first time. But the second one, she didn't want to go further because she was already 40 and other financial issues. So her option was to interrupt the second pregnancy.
Oh, so she didn't carry the second pregnancy.
Oh, no, she didn't. She was very upset, actually, because she didn't had financial conditions to have a second child. And although we would give the support as we did in the first pregnancy, but she was also very worried about that disease might come back, and we don't know what can happen because she had a previous mutation that it's not the best mutation for nilotinib as well, if the same mutation come back.
Yeah, Katia, thank you. And Carla, I'm going to share some thoughts that I think are a little bit hard to state, but I think it's really important to state them. I'm very enthusiastic to help women with fertility and pregnancy, but I'm also quite serious about it. And I often see women in the U.S. in my own practice who they're not exactly in the right of circumstances to continue a pregnancy. And I always take a very serious conversation with the woman and her partner, whoever's the support for the pregnant person is, to explain to them that, we can be very hopeful and we have tools and we can treat. But I literally will bring up the notion that if the CML destabilizes and becomes worse, that it could be that the life of the mother is in danger, and the life of the mother may be lost, even in the absolute worst case scenario, if the CML is not controlled, if it progresses to a blast crisis. Even that is treatable. But so I think it's really important to make sure people proceeding along these pathways understand all the potential risks. And I think maybe her decision was personal and financial, and each woman should make her own decision, of course, about these things, or a couple or family. But I think speaking frankly to people about all the possibilities, because I'm extremely enthusiastic and hopeful to all the women I take care of that are pregnant, but I also have to be realistic. So I think that was that decision was okay, and I just as you did, Katya, probably supported her, and I'm happy she's doing well now, and she has her earlier child who she successfully delivered, so that's great. The two questions, just so I answer them, were we covered a little bit actually before that. I ironically, nilotinib I think may offer less risk of damage during development to the fetus, based on our observations of pregnancies that have been published by several different groups and registries. And I want to applaud there's some global CML community members, Elisabetta Brussier and colleagues in the Soviet Union and the UK, Jane Apperly and others, who have really contributed to the global understanding of pregnancy and outcomes. So I stand on the shoulder of people who have been hard at work gathering this data for decades. So the interferon use, I would say the same. I think it's an option. I may be lucky. My experience has been good, where I've actually seen women respond to very little exposure. And but again, just want to emphasize that comment to proceed with caution here, but in full support of a woman's right to start a family, just like this lovely picture is showing. I mean, how can you not want to do everything you possibly can in this setting? but smartly and with science and with evidence. So let me stop there so we can leave some room for questions or comments.
It's she had a pulmonary hypertension and she had to switch the inhibitor. Our only option that we have was linotinib, but do you think this would be a case for using, for example, asciminib or ponatinib as a third TKI, or would you be okay with nilotinib?
That's a nice tangent. I think first of all, I want to applaud you for doing a catheterization to determine the lack of pulmonary hypertension. That is perfect, because that's an underdiagnosed complication of dasatinib, and it only really can be identified properly with cardiac catheterization rather than echocardiography. So well done. And yes, I think 2 TKI exposure in a case with some earlier resistance, I think you want to talk about multiple options. Bosutinib, nilotinib, ponatinib may represent greater risk benefit than needed, especially when there was some cardiopulmonary toxicity. And asciminib, I think, offers a new option with less cardiopulmonary toxicity, at least so far, and a unique mechanism of action. So I think that's a great point, Katya. I think you're spot on. I would have hoped to have had all those options, but I think you did the best with what you had, and nilotinib was reasonable.
So we're now open to all questions from the audience. Virginia Abayopolo says, how do you plan the discontinuation for patients in MMR that want to discontinue to get pregnant?
Did you want me to answer? Well, I guess first reaction, I'd say I aim for better, because MMR is very good and very safe, but a deep molecular emission would be better. But so that's a great question. I've taken that in many different ways. My best answer would be that a woman know her fertility, know her cycles, and if someone's planning a pregnancy and saying, I'm going to get pregnant, I'm going to stop my TKI, how do I do it, doctor? Please help me. I would say, take your medication, know your fertility, know when you're fertile. If you have attempted to conceive and you believe you may have conceived, stop your TKI. Wait and see if you've achieved pregnancy. If you haven't, you have a period when you can treat again. Go back on your treatment and do that until you have successfully become pregnant. That is very complicated. That requires a lot of teamwork and a very committed woman. But I try to achieve that, and it allows for intermittent treatment. I don't know how effective that is. I haven't studied it prospectively, but I feel it may be better than stopping entirely for attempts at conception, which could take months. If a woman may not be successful for several months, like you could essentially have a very long prodrome of time off treatment and relapse before, and then you achieve pregnancy, and now you have greater disease volume that needs to be managed during pregnancy. So when I can, I try to use some intermittent TKI treatment. That's my secret recipe for that. So I'm not saying that complete discontinuation if a woman doesn't have access to rapid pregnancy testing or that kind of knowledge about fertility. That may be more practical, especially in in many scenarios. So only when possible.
Lillian?
I wanted to ask you about a case of a 38-year-old woman that got pregnant, and that her first control at 8 weeks of pregnancy was diagnosed with CML. She had a white blood count of 52,000 and 899,000 platelets. So she was studied, and a low so-called risk score of CML was diagnosed. And her platelet count went up until 1,004,000 platelets. What would you do in that case? And if you indicate interferon, do you use the pegylated form or the traditional form?
So that was Carla's scenario number 2, I think, CML diagnosed during pregnancy. I think you immediately want to think about options to control blood counts. I think leukapheresis is an option, although it's obviously very temporary. I think interferon would be very reasonable to consider in a case like that. I I do use pegylated interferon historically. I don't know if there is short-acting interferon out there. If there is, I think they're both options. They may be more challenging. Just to raise the issue, when the platelet count rises to that level, there may be interference with von Willebrand's and acquired bleeding from that. So that may be a consideration. In that case, the platelet count may be more of a pressing issue over the white count to maintain a safer pregnancy or to get the woman to delivery, especially with the potential bleeding risks during delivery. So what to do about that? Again, interferon can control both of those in theory. This might be a patient where if control is difficult and you get to the 3rd trimester, you could consider, again, I don't say that this is per the label or per the manufacturer, but one could consider imatinib or nilotinib in the 3rd trimester. But that's the way I would view it. I would be cognizant of all the potential pitfalls, try to get the woman to delivery with safer numbers via leukapheresis interferon, try to avoid interferon hydroxyurea. Anagrelide is, I think, a little less of a concern, also it can borrow from sort of the MPN field. What do we do for women who are about to deliver who have thrombotic risk, maybe, although CML doesn't have much thrombotic risk with high platelets or with uncontrolled disease, but there's often a use of low molecular weight heparin after delivery, after safe delivery, as a preventative to prevent postpartum complications, and aspirin therapy, with thrombocytosis.
Well, we started interferon at week 13 and low molecular weight prophylaxis, but we didn't have experience with the pegylated form in pregnancy. And at 20 weeks of pregnancy, she was diagnosed, or the baby, with a bilateral hemimelia of the fibular bone. So she carried on well during pregnancy and didn't have a complete hematological response, but the baby was born okay, but she really had bilateral tibial hemimelia. So I was wondering if that could be an adverse event or of interferon or just a casual association. She, after delivery, initiated imatinib because she was low risk and has a good response at the moment.
I think there have been, collective data for interferon and MPNs broadly, TKIs and CML, and there are a collection of fetal anomalies that have been observed. I'm not sure if that particular anomaly would be directly linked to interferon. One might wonder. But I think interferon has been viewed as generally safe and not particularly associated with specific developmental or structural defects in children. So that might not be related. So, but I'm glad it went a bit better than the worst case scenario, that mother and baby were at least safely delivered and okay. I want to be sensitive to the time, Arlene.
That's okay. I was just going to say in the last couple of moments, if there's anything that Carla or yourself might want to say as a take-home message, a final comment that you'd like to give.
I'd like to thank, because this is very, very many cases that very a challenge for us. Then I have just a fast. I have some patients that I am trying to stop the drug to be pregnant. Then I have one patient that she prefer stop the drug and don't wait for the 6 months each month to achieve the PCR, because for her she will have more time to finish the pregnancy and here start again if is could be possible. Just for illustrate the very this is a great challenge for us, the pregnancy in the CML. Thank you so much, Professor Mauro.
I want to thank the ICMLF for all the work they do, and this great audience. I mean, I think these are both areas of where we need more knowledge, and having such great colleagues to discuss what we know, what we can do, and to bring cases forward, and especially at a global level. This is phenomenal. I just love being part of things like this. And Carla, I know exactly what you're talking about. I often get women who want to, there's no waiting. It's TFR and pregnancy both at the same time. So I don't always negotiate successfully to think about TFR first and then pregnancy later. But I hope we can hear more on this and learn more on this in the future. And again, thanks and hats off to the ICMLF for all they do.
Thank you. Thank you both for such an active discussion and for participation. That's been great. For all of you who still have questions, comments, cases, send them to me. I will get you a response and get back to you as soon as I can do. And we hope to see you soon. There are 2 other Latin American discussions which are currently scheduled. 27 April, we have 2 topics, the realities of TFR and from the laboratory, and a great team of experts will lead those discussions. On the 25th of May, we'll do things a little bit differently, and we will have a presentation and discussion of 6 challenging scenarios. Again, a wonderful team there. It's going to be a great discussion. I would like to draw everyone's attention to the ICMLF Knowledge Center. It really is a wealth of knowledge there, spread across a number of different modules. As you can see, there are many presentations from leaders in the field. We're currently halfway through the pediatric model, and a model on pregnancy will be rolled out later in the year, as well as the management of advanced and blast phases. But I will send you some links and encourage you to go and have a look there. And in the meantime, we hope to see you at one or both of these forthcoming discussions. And thank you, gracias y obrigado.